Welcome to Beyond the Limits with your hosts, Matt Clark
and Mike Forsyth. We're delighted today to be joined by Dr Hugh Coyne, who is a GP and a men's health expert. Hugh, welcome to Beyond the Limits.
Mike, Matt, great to be on. Thanks very much for having me. Really appreciate it.
Yeah, great to have you on, Hugh. Today, we're talking about testosterone, aren't we? I don't know about you, Mike. I literally cannot escape this as a subject at the moment. I think the algorithms are conspiring against me or playing into some awareness that maybe I'm testosterone deficient or something, but I can't seem to escape this. And I think this is a really, really important topic to debunk and to get under the microscope. And it's great to have you on, Hugh, to do that.
And this plays very much into my conspiracy theory that I have, that every episode we decide to do, suddenly this big influx of news stories. Even just last week, top story in The Guardian was about how people were illegally using testosterone to boost their performance. And then actually, interestingly enough, I was reading an article from someone who I think is in reality TV, or maybe Strictly. Is that reality TV? I don't know. But who was coming out and saying that they've actually been addicted to testosterone for a while now and are talking about the ill effects that they've had as a result. All I can deduce from this is that the mainstream media are listening to us in some way, and that's why they're focusing on the topics that they are.
You guys have clearly been bugged. I would check those microphones carefully.
Exactly right. Well, Hugh, thanks again for joining. I know we're going to talk a little bit about testosterone deficiency, but we're also going to be talking about the misuse of testosterone. But should we go back to the basics here? So what is testosterone and why is it important?
Yeah, that's a really great question. And it might seem a little bit basic, but it's actually really important to understand because there's a tendency to pigeonhole testosterone and oversimplify its role in the body. So testosterone is the principal androgen in men. It is thought of often as a purely pro-sexual or pro-anabolic agent, and that it is something that is essentially just for the bedroom and the gym. But clinically, that's a massive oversimplification, and we need to think about testosterone as a much more ubiquitous molecule because androgen receptors are expressed all over the body in almost every tissue type. It has a multitude of roles in the body that is not just related to libido or erections or aggression or building muscles. So in the brain, testosterone acts as a neurosteroid. It is very important in our cognitive architecture, in our memory retention, in our emotional regulation. So when levels dip, people don't just lose their drive, they lose their spark, or to paraphrase Austin Powers, they lose their mojo. And often this presents with brain fog and depressive symptoms. It also has a big impact in cardiovascular systems. It acts on the kidneys to stimulate EPO, which is why we monitor full blood counts in people who are taking testosterone, and why its effects in athletes are much more than just muscle bulk because it raises their hematocrit, so they get much more oxygen delivery to tissues. In the skin, it has lots of effects, so everyone will know about the side effects, that it can increase sebum production, so people get acne, but it also affects collagen synthesis. So you'll often notice in these guys that you're seeing online on these testosterone adverts or these fitness influencers or influencers who are perhaps ostentatiously promoting their physique to promote their business, is that their face will look different and they will have more collagen in their face, which causes that characteristic puffiness. And then it's also really important in bone mineral density and, of course, muscle protein synthesis. So it's a whole system molecule.
When you talk about it being a hormone, it's ubiquitous and it has impact and effect everywhere. I think we should talk about the symptoms and the signs of low testosterone, because we've already alluded to the fitness bros and the promotion of testosterone deficiency and that phenotype that is typical or is expressed as being deficient in testosterone, like you said, the kind of meek or a patient lacking libido. But it's so much more than that, isn't it? And it's so important that we outline that today. Because of all of those different uses that you've just outlined, what are the kind of key symptoms or signs of someone who actually has low testosterone?
The characteristic symptoms would be things like sexual dysfunction, so reduced libido, reduced morning erections, then more widespread symptoms such as fatigue. People may experience reduced muscle mass, decreased energy. As I mentioned before, the loss of that spark, that mojo. They just don't feel like they have the same zip that they used to. Very often it will present with depression. Because these symptoms are vague, it really lends itself to this easy characterization of symptoms. And I think that is one of the issues perhaps that relates to its overdiagnosis in some spheres, so particularly online prescribing by clinics that are specialists in testosterone replacement, because I think the way the question's often framed is, do you feel like you're lacking in energy? And well, of course, I always feel like I could do with a bit more energy. Do you feel like you could do with better or stronger erections? Well, yeah, absolutely. Do you want to have more spark? Yeah, yes, please. And do you want a better libido? Yes. And could you do with bigger muscles? Definitely. So it's very easy to feel like that while you might not have the characteristic symptoms, that perhaps you're not reaching your full potential, or certainly not the potential of the people that you see on social media who seem to have all these boxes ticked.
Feels like a double-edged sword in some ways, because I think we've talked a little bit already about these online companies and in fact beyond that, social media and whatnot, kind of playing off those vague symptoms and saying, look, is this your testosterone? And actually in a lot of cases that's not what's going on, but that's the position that's being pushed. But the other side of this is that actually low testosterone does happen and can be a real problem, as you alluded to in your last answer. So who does suffer from low testosterone? Who is at risk here? And how do you know if you are that person?
Testosterone deficiency, I think, is unusual because it suffers from both under and over diagnosis. And it tends to be overdiagnosed in the people who least need it and underdiagnosed in the people who most need it. Typically, people who would be at risk of testosterone deficiency might have overweight or obesity. They may have type 2 diabetes. They may have chronic pain, in which case they're taking opioid analgesics over the long term. They may suffer from anxiety and depression, so maybe taking medications such as SSRIs. These are the big risk groups that we would see that are likely to have testosterone deficiency. And of course, some of them will also have conditions like obstructive sleep apnea, which will be incredibly disruptive in testosterone production. So it's thinking about people who have metabolic syndrome, diabetes, cardiac disease. Those are the real at-risk groups.
Having read more into this, I've become increasingly aware that this is actually much more common than I first thought. And like you've just said, these patients with metabolic syndrome, the type 2 diabetes, obesity, these are all really, really, really common, aren't they? And they're getting more common in our society, and how testosterone deficiency association with that is obviously getting more common. It might just be worth outlining what the link is between something like the metabolic syndrome and the obesity and testosterone deficiency. What is the physiology there?
It's essentially suppression of the HPA excess that is causing that in both obesity, metabolic syndrome, and type 2 diabetes. And so we would term that as a sort of functional cause or a secondary cause, as opposed to the primary cause that we often learn about in medical school, which tends to be related to an issue that is congenital with the testes themselves. The other groups that I think are important to mention as well, who will often get it, are people who have previously used androgens. So people who have illicitly used anabolic steroids. That would be relatively big group that I would see here, actually, that people have used it in their 20s or 30s and then come in later having the characteristic symptoms of testosterone deficiency. And then the other group would be people who exercise excessively, like those who do triathlons and ultramarathons. And essentially that is another way of suppressing the HPA axis.
These idiots.
Don't want to name names or point fingers at anyone in particular.
And so, Hugh, if we have any listeners, or if you have any patients that you see who are worried about whether actually their testosterone may be reduced or low for whatever reason, I know, as we talked about, those symptoms can be quite vague. So are you able to just outline for our listeners how we actually test for this? How do you know if you have a low testosterone? Are there important things to remember when it comes to doing that test?
Yeah, it's really important that the testing is carried out correctly to get a truly valid and clinically meaningful result. So the diagnosis requires both the characteristic symptoms that I mentioned, so sexual dysfunction, fatigue, reduced muscle mass, and low serum testosterone levels. And this is a total testosterone of less than 12 or a free testosterone of less than 0.225, confirmed at least twice on 2 separate morning readings. So ideally done fasted and before 11 o'clock in the morning to coincide with a physiological rise in testosterone levels. And it's really important in terms of the timing because some unscrupulous providers will be testing at inappropriate times. So testing, for example, in the afternoon and finding that people have low testosterone and then offering them prescriptions for testosterone replacement. So it's really important to test twice as it is with any hormonal test. You know, if we were doing someone's thyroid function test, the TFTs, we would not rely solely on one reading. We would check it again, as is the case with any sort of abnormality. And that's a really important nuance to it.
Yeah, I'm really glad you mentioned that. I posted something on LinkedIn a little while ago, taking some umbrage at a patient who had presented with a finger prick test. And I wasn't taking umbrage at the patient, but I was expressing my frustration with some of these finger prick tests and how the uneducated use of these is just wasting time and wasting resources, having patients presenting with, doctor, look, I've got these symptoms. And like you said, if the test isn't done correctly and not appropriately, then it's not accurate, it's not helpful. I guess it's worth mentioning on the testing as well. There are quite specific things we need to look at, aren't there, in the blood in terms of free testosterone and also something called the sex hormone binding globulin. Do you mind just outlining why that's important?
Yeah, absolutely. So I mentioned there about the idea of checking either the total testosterone or the free testosterone. So when we are calculating free testosterone, we take into account the patient's albumin level and their level of sex hormone binding globulin. And that allows us to calculate the free testosterone. There's a free testosterone calculator online, which is incredibly useful. And that is valuable because we get a really accurate picture then of what are the different factors that could be involved in their testosterone level being abnormal. So, for example, someone for a variety of reasons might have an abnormally high sex hormone binding globulin. That means that they have a slightly low free testosterone. And this is something that is very likely to spontaneously resolve over time. And for example, that can be related to training response, for example. So it's important to think of both of these factors, both the total testosterone and the free testosterone. And then the testosterone itself, especially when considering testosterone replacement, shouldn't just be thought of in isolation because of it being such a ubiquitous molecule. So it's important, if you're testing and considering prescribing testosterone replacement, that you also check that the patient's liver function is normal, that you check their lipid profile because of its impact on the cardiovascular system, that particularly checking the full blood count so that you know what the hemoglobin and the hematocrit is, because both can be increased by taking testosterone, particularly if the dosing is a little bit on the high side. And then also really important to check PSA levels as well and make sure that they're in the normal range. So it's not quite as simple as just checking it in isolation. It needs to be done as part of a full workup. The other thing as well that's really important is that obviously if the testosterone level is low, you also need to know what the LH level is, the FSH level is, what the prolactin level is. So we want to know, is this actually an issue that is related to a pituitary problem? So it's trying to go down the appropriate diagnostic pathway rather than rushing in to prescribe testosterone replacement.
I just wanted to go back and ask about specific levels of testosterone and particularly the variance between one person from the next. So I've certainly had patients who have come in and said to me two things. One is, I've tested my testosterone on the NHS and it's told me it's normal, but I've spoken to someone elsewhere and they say that this isn't normal, this is a low range. So I guess the first question is in terms of what's your answer to that? And then the second situation that I've had is where people have said, well, yeah, my testosterone is normal, but my friend had it done and theirs is actually higher range of normal. So can I get some testosterone to bump me up? That, when I say it, sounds ridiculous, but is there any truth to that whatsoever?
Yeah, again, that's a great question. So I suppose the couple of things to consider there is, one, the usefulness of free testosterone there, because obviously people will have differing levels of albumin and differing levels of sex hormone binding globulin, and this is going to impact on their level of free testosterone and their bioactive testosterone, as opposed to just their total testosterone, which is a little bit more of a gross number, if you like. So it really isn't useful to compare people's total testosterone levels. And like anything, there are a variety of factors that can impact on that. And then the other thing that is really important to think about is the androgen receptor. So it's not just enough to have testosterone circulating. You have to have androgen receptors, and these are determined by our genetics. So sometimes you might get that clinic who might have a normal serum testosterone level, but they have some of the phenotypic features of having a deficiency, and that will be related to their genetics, essentially. So the testosterone is there, the body is not responding.
Okay, we've done a great, well, I say we've done a great job. You've done a great job of highlighting how complex this picture is, but also how maybe important this is and this discussion is. Let's think of a scenario. So we've got a listener. They have had a few symptoms. They've gone and got a test. They do have confirmed low testosterone. It's been confirmed on a second sample. It's been taken appropriately, and we want to do something about it. What can be done about it?
Like everything in medicine, we sort of think first about lifestyle interventions. So particularly with those patients with metabolic syndrome who might have obesity, who might have type 2 diabetes, a really important intervention is to lose weight, to try and decrease their subcutaneous and visceral fat, increase their muscle mass, and all of that can be really helpful in improving testosterone levels. But the current guidelines suggest that lifestyle interventions alone are insufficient for men who need replacement. And in terms of replacement, there are a variety of options available. So we have a few different options. So recently, there is an oral testosterone. So previously, oral medications were thought of as a bit of a pariah, and even in people who took anabolic steroids, they were well known for, causing cholestasis and hepatitis and being a bit of a disaster. But there's a new class of oral testosterone available, which is undecanoate, which is licensed in the US. So it's recently been granted approval by the FDA. I think the challenge with them is compliance, because they require twice daily dosing, and to be absorbed adequately, they need to be taken with a fatty meal. So it's not ideal for the people that like intermittent fasting, for example. There's a couple of different injectable options. Well, there's several different injectable options, but essentially there are short-acting esters. So there's ananthate and cypionate. So these are relatively cheap. They're very effective. They are typically prescribed over 14 to 21 days with some tweaking of the dosing according to people's response. But what some people find is that they get to a certain point, say by day 14, and then they have a bit of a crash and they feel really awful, feel a bit emotionally labile. And what people often do is what is referred to as microdosing. So they will split the dose into smaller doses, which they might take twice a week or they might take daily. Then there's a long-acting injectable, which is the undecanoate, like that oral preparation. So that's one that we'll be quite familiar with. It's long-acting. It's typically one injection every 10 to 14 weeks. So it leads to very good compliance, but the problem is it's a fairly uncomfortable injection. And the other thing is that it provides this steady state that doesn't really mimic our physiological production of testosterone. And the other thing is that obviously once you inject it, you can't uninject it. So it's there for that duration of the treatment. And then there are the transdermals. So there is a transdermal cream, which is made in Australia, and people can get it in the UK. The testosterone cream can be applied to the scrotum. And there are several gels that are available, which I think are probably the most seductive ones to prescribe as the doctor because there's no needles involved. I think gels always seem very, very easy. They are used daily, so they provide a very physiological profile that mimics the daily circadian rhythm, but it's a bit of a kind of lifestyle commitment. It's people worry a bit about the transference of the gel, onto a female partner or to a child, which has happened in the literature. And also, it's just a bit of a pain rubbing these gels on as well. And then another more recent treatment is nasal testosterone, which is particularly useful because it's thought not to impact on hypothalamo-pituitary axis as much, but it requires quite frequent dosing. So I think it's 3 times a day. There are lots of options and very dependent on the patient and their motivation, what their preference is, and also, I suppose, as well, like lots of things with what the doctor is most comfortable prescribing. I think one of the things that is sort of nice about the gel is that it seems very normal and medical. And once you start prescribing the injectables, you just start thinking about Ivan Drago in Rocky IV. And that there seems something a bit wrong about prescribing this stuff, but there absolutely isn't. The right patient, it is absolutely the right thing.
It's interesting you mentioned that, because I think that discomfort that we as clinicians sometimes feel, I think a lot of us still feel that to a degree, because it feels as though whether it's a gel or whether it's an injectable or whatever, feels like a big step, particularly in primary care. And I just wondered, what are the risks here? I know you mentioned PSA, and I know that's one that often clinicians will worry about in terms of this having an adverse effect upon someone's prostate-specific antigen. What are the risks here in terms of testosterone replacement?
I suppose that the first thing that I should say before I mention the risks is it is really important in men who have low testosterone and symptoms that they do get testosterone replacement, because it does effectively improve their sexual function. It will improve their body composition. It will improve their bone mineral density. Their metabolic health will be improved. It also can reduce progression to type 2 diabetes in men with pre-diabetes and low testosterone. But like anything, it does come with risks. So it can very frequently cause polycythemia because of that stimulation of EPO production from the kidneys. It can very commonly cause prostate enlargement. It can itself cause sleep apnea. This is because of the soft tissue enlargement, the collagen deposition that we were talking about. So it can cause snoring. It can, in fact, cause the very condition that we might be trying to improve. Really important, it can impact fertility by reducing sperm production. When we give exogenous testosterone, we will suppress the LH and FSH, and therefore there will be less spermatogenesis. And then there's concerns about prostate cancer. And actually, the guidelines from all the major urological and sexual health organizations can't find any strong evidence that links TRT to increased prostate cancer risk. In fact, some studies suggest that lower levels of testosterone are actually linked to more aggressive prostate cancer. So in terms of the big concerns around prostate cancer, I think we can be quite reassured, but prostate assessments before starting TRT and regular monitoring during treatment, I think, is still essential to do. Testosterone can improve survival in men with type 2 diabetes, and it seems to be well tolerated, potentially life extending. Dare I say, it might enhance longevity in the right people. So for those who need it, testosterone replacement can be very useful, but there's certainly a gross overestimation in some groups of those who need it.
That nicely summarizes the risks there, Hugh. We're talking, I guess, the risks about a treatment when this is indicated. And we've touched upon at the beginning of the episode about how there seems to be a lot of usage outside of the actual appropriate prescription. I think we can all probably think of the reasons for this. There's a big push in terms of people's body image, and testosterone is obviously going to help with that in terms of muscle mass. So how is this being abused?
This is a really interesting cultural phenomenon. I think that has been fueled first, as you mentioned, by the proliferation of social media. I think there is a progression of politics as well that is really pushing a particular anti-woke kind of libertarian agenda that is heavily influenced by right-wing politics and the transhumanist movement. And the third is that there is an evolution of medicine, rightly or wrongly, from a sort of treatment of sickness model to a more preventative model and this growing sphere of longevity. And I would call these sort of confluence of factors personal enhancement medicine. So they might be thought of like the Frankenstein's monster of the longevity health sphere. And in terms of social media, I think there is undoubtedly a huge impact of the sort of brotocracy, the gym bro, the male health influencers, and there is certainly, I think, a male obsession with wellness at the moment, and it predominantly this sphere is inhabited by men who are trying to reclaim their masculinity, and they are doing so by trying to physically look like real men. And a lot of these online fitness idols or longevity idols or people who are idols in business. So obviously I own a clinic, so I get a lot of these entrepreneurs on my social media feed. And part of their shtick is that their fitness is especially conspicuous. They promote health, they promote fitness, and they promote strength, but it is their buff appearance that is the most conspicuous thing about them. And the other thing that I'd say that's really noticeable in social media is that as rightly men and women have become more equal in society, that the expectations of our appearances have sort of drifted towards these more gendered extremes where men are supposed to look like real men, over-muscled, powerful, predatorial, kind of master of the universe. This adds to the pressure on men to take testosterone when they don't really need it. And I think that use of testosterone and where it's not appropriate has become incredibly ubiquitous, and it comes with all kinds of potential side effects. Lots of people in the bodybuilding sphere will know about its impact on male pattern baldness. They will worry about testicular atrophy. They will worry about acne from the increased sebum production. The characteristic face that I was discussing earlier from the excess collagen that causes this puffiness in the face. But then, of course, there are more serious side effects. And there was a really recent, very interesting study in professional bodybuilders that showed that despite their incredible leanness and well-muscled physique, that they had significantly shorter lifespans. And the main factor that is likely behind that is their use of testosterone, because to all intents and purposes, they are otherwise very healthy. And of course, there are other performance-enhancing medications that they will be taking that will contribute as well. But certainly testosterone is a big part of that. And even thinking about the excess red cell production from testosterone's impact on the kidneys leads to the increased risk of blood clots. And I've chatted about with you guys before. We were reminiscing about Tour de France cyclists getting up in the middle of the night to get on their turbo trainers because they've been taking EPO and were needing to maintain some sort of increased level of circulation so that they didn't spontaneously clot. These are real risks for people who are taking excess testosterone because their hematocrit will become incredibly high if they're taking excessive doses.
And then with prolonged use, that will lead to their own production of testosterone essentially not working because of the axis that you described. So I guess then you can potentially get in that position where you're kind of almost a victim of your previous actions and that you need to keep taking this, right?
Yes, exactly right. These people have shut down their HPA axis. They can no longer produce their own testosterone. So now they're dependent on the provision of exogenous testosterone.
We've talked about off-air about something called the enhanced games and how this is a form of Olympics where athletes can take anything they like. It's almost kind of promoted to see how far the human can go with artificial enhancement with exogenous products, testosterone being one of those. Have you heard about this, Hugh? Have you had any thoughts on this?
So I think the enhanced games is fascinating. I love sports. I love the Olympics. And the founders of the enhanced games are very critical of the Olympics. But the Enhanced Games is quite a different beast altogether. So as you mentioned, this is a sports event where they're actively recruiting recently retired athletes and then allowing them to compete with the use of performance-enhancing drugs. Now, this is supposed to be under the supervision of a doctor, and this is being heavily influenced, again, by this transhumanist movement. So it's perhaps no surprise that Peter Thiel is one of the big backers of this. So this transhumanist movement being the idea that through the use of technology that we can enhance our human abilities, extend our lifespan, improve the human condition and overcome biological limitations. And I don't know if you guys remember this. I'm Irish, a big fan of the comedian Tommy Tiernan. He years ago did a skit called The Drug Olympics. And Tommy Tiernan joke is now an actual event that is occurring next year in Las Vegas. And it's really interesting because although we might think of it as just being a sports event that will have, athletes that are freakishly talented anyway, but will have their performance enhanced, and that might make an appealing watch. But essentially the Enhanced Game is actually an advertorial. It's actually a marketing trick. And wish I'd come up with something so creative for our clinic. We'd be completely overrun. We'd be so busy. But it is a telehealth company that is selling testosterone online. So you can now go on the Enhanced Games website and you can register to buy their products, which includes testosterone. So instead of us mere sports fans wanting to have the Lionel Messi Inter Miami jersey or the Cristiano Ronaldo boots, we can actually get the same drugs as our sporting idols are using, which to me seems quite extraordinary. I applaud their creativity and their marketing, if not all of their morals.
Yeah, it's fairly terrifying, isn't it? Just hearing that expressed out loud, really. Look, I think we're kind of drawing to a close here, but I think a really interesting topic, and actually so many different facets to this. I think that's my takeaway from this, because I think that the vagaries of the symptoms of low testosterone have really been jumped upon, I think, by so many different companies, as we've discussed. And I just do feel sorry for a lot of people who are feeling a bit fatigued and a bit low in libido or low in mood for various reasons, who then get, it's sharks in the water, really, isn't it? They're encouraged to have their testosterone checked, and then they get into this cycle of being constantly told that they need to have better muscles and be more energetic. And then the other side to this is just there are people who are genuinely low in testosterone who really do need treatment. I really like your phrase about how it's both an under and an overdiagnosed condition.
Yeah, I really like that, because I think that references the boom on social media of the upselling of this versus actually the underdiagnosis, the how we all need to be a bit more aware of this being an actual problem, and it being increasingly common with the likes of obesity, type 2 diabetes and metabolic syndrome, like you've outlined nicely.
Yeah, thanks very much. It's been a real pleasure, and I'm so glad to be on and talk about it.
Hugh, thank you so much for joining us again. And as always, please follow our podcast, please share it with a friend, and we will see you next time.
Thanks, Hugh.
Thanks, guys.